We have two speakers, so we're really delighted to be able to present the fellowship program that's funded by European Commission, which brought us two visiting PhD students, as well as the work that they're leading while in Toronto this term. So the North American Observatories on Health Systems and Policies, which I'm the Director of Operations. I'm Sarah Allen, for those of you who don't know me. I'm really delighted to be working with the IHPME and with Canadian Institute for Health Information in this collaborative fellowship training program with the Amsterdam University Medical Centre, where the two speakers you'll be hearing from today are currently full-time PhD students in Amsterdam as part of this fellowship program. And the unique feature of the program is that it allows students to have placements in two national and international institutions, sometimes in private sector, sometimes in government, and always with a partner academic institution. So the University of Toronto was part of this application at the outset that was successful in getting funding, and so this is why we're the lucky hosts of fellows who are coming. And so our first two fellows have been here since September and are really pleased to be able to speak to you about the work that they've done here, as well as to provide some context for sort of the rationale for the broader training program, which is about how performance data can be used and optimized in improving healthcare systems. And the two topics that we'll hear from that they've been delving into deeply is one is a project with the Ontario Hospital Association, which we're really pleased to have some partners here, which is asking managers how they use data in hospitals in Ontario. And the other study that Mircha will be presenting is on long-term care and how performance data that's publicly reported might incentivize improvement in long-term care facilities in all of Canada. So I'll turn it over to our fellows, and we'll have some time for discussion and questions towards the end. But if you're unclear about something, if there's an institution or acronym that's from Europe that you're unfamiliar with, please interrupt and ask the question so that we don't have too much, so we're all on the same page. But leave the substantive questions to the end. We're video recording this so we can post it on our YouTube channel after it's edited. Questions and answers at the end won't be part of that. So we can feel free to have an open and candid and hopefully enriching discussion at the end. So I'll turn it over to first Damir to introduce himself and the program.
Thank you. Thank you, Sarah. Thank you, Sarah. Yeah, if there'll be any questions about acronyms, feel free to ask. Although we've been struggling with acronyms here in Canada, they are quite huge, we realized. So basically, as you'll see, this placement of ours in Canada is split between CIHI, so the Canadian Institute for Health Information, and here at U of T at NAO. And at first day at CIHI, we literally got this like 5-10 page printout of all the acronyms used there, which turned out to be quite useful. Yeah, so as we've joked before the lecture, we'll do a bit of a sandwich technique here. So I'll introduce the HealthPros project that brought us here. Then Mircha will talk about his work here in Canada, and at the end I'll talk about my work in Canada, but mostly the previous work in Europe that brought me here also. So yeah, optimizing performance intelligence in health systems. That's kind of what the HealthPros project is all about, and we'll spend a few minutes talking about the project itself. Then we'll talk about our work here, as I said, and we'll announce more fellows from the same project coming next year. First, let us introduce ourselves. So my name is Damir Ivankovic. I'm a Croatian originally, doing my PhD program now in Amsterdam. Same as Mircha, and I have an educational background in medicine and business administration, public health, worked for the ministry, worked in the medical devices industry, did a bit of clinical medicine also, and the last thing I did before starting my PhD was a public health residency back in Croatia for the National Public Health Institute. Mircha?
Yes, thank you for holding the mic. I'm going to go around so that you can see the slides and he can hold the mic. So yeah, my experience is actually quite similar to Damir's. I also studied medicine. I'm from Slovenia, neighboring country to Croatia. I have some experience working at the Ministry of Health, at the National Institute of Public Health, and basically just as Damir, we moved to Amsterdam for our PhD in October 2018, so about a year and 3 months ago.
Yeah, thank you. Yeah, so HealthPros project, I don't know how many of you are familiar with what it's about. So as Sarah mentioned, it's a European Commission, so European Union funded training program for healthcare performance intelligence professionals. And kind of the copy of the program is making effective use of available performance data, and that's what all of the fellows within the program are working on. It's been funded through the Horizon 2020 Marie Curie funding mechanism, which mostly funds PhD and postdoc level education in Europe. So the rationale behind basically writing the proposal for this project, and that was a few years ago, and Sarah was also involved, and NAO, IHPME, is basically that in Europe and worldwide, there's of course the challenge of dealing with the triple or, in the meanwhile, quadruple aim, and also the V's of data in healthcare, so volume and velocity and value and veracity, and I forgot the fifth one. It should be variety of data in healthcare is basically increasing, so we are all aware of how much data we have these days in healthcare. But what we do with it, there's a huge momentum in the scientific, but also community, but also politically and socially about doing something about all this data in healthcare. And that's what few universities in Europe that started writing this proposal, I think now 5 years ago, were thinking of, saying we need to redo our training programs and start educating the new generation, basically, of healthcare intelligence professionals. And yeah, that was the rationale. And what HealthPros project aims to do with its, as you'll see now, 14 fellows, PhD students, is to deliver the next generation of healthcare performance intelligence professionals that can make effective use of performance data to improve integrated care, patient engagement, equality, outcomes, and reduce waste. And basically, these are the topics that the fellows are working on for their PhDs around Europe. So when I say around Europe, the original group of beneficiaries that applied for this proposal was 6 institutions, 4 universities, 1 academic hospital, and 1 private company. And this is one of the prerequisites of these Horizon 2020 projects, that there is always the industry involvement. So the 6 universities are the Corvinus University in Budapest, Pisa University in Italy, Amsterdam, University of Amsterdam, and the Amsterdam University Medical Centre in the Netherlands, and the University of Surrey in the UK. Research team is right now in the process of moving to Oxford, so that's a small change in the project. And then there is the academic, the University Hospital in Aalborg in Denmark. It's a psychiatric hospital, and the private company is in Germany, in Hamburg. It's called Optimedis. It's a company that does healthcare data management, mostly focused on integrated care. But you can see a lot of other partners, and also the Canada there. So project, besides its 6 core beneficiaries, has a number of partners throughout Europe and in Canada. And that's mostly used for fellows to do their placements and do part of their research in another location. In Canada, these are the partners, so CIHI and the university, so Institute here of Health Policy Management Evaluation, and NAO. The project, being a European Commission funded project, is set up through work packages, as all of them are. And basically the three main work packages are where the fellows do their PhD research. And these are kind of set up through this pyramid that you can see of what happens or working with healthcare data. So from data to acting upon data, turning data into information and knowledge, and talking about indicators. So these three main work packages are working on measurement topics, working on governance topics, and using the data, so utilization, acting. Yeah, and there are the dissemination and the management of the project work packages. These are the 13 fellows. There's going to be additional one in Oxford soon. And it's a very international group of students. So the fellows come from Canada, Taiwan, Mexico, New Zealand, Portugal, Netherlands, Croatia, Slovenia, obviously, China, Turkey, Chile. I think I mentioned all the countries. So it's a really a global group of fellows with diverse backgrounds. So some come from medicine, some come from epidemiology, health economics, IT. So it's a very diverse in terms of educational and professional background. And most of these, although we are all employed as early stage researchers, most of the fellows did a few years of working experience outside of academia and now decided to do research, which is an interesting moment, I think, in the project itself. So what's special, besides all the things that I mentioned, what's special about the HealthPros project is, I think I proved that it's an international group of fellows, a global network of beneficiaries. Also, we have semi-annual training weeks, which include immersion community events, meaning that every 6 months we meet in one of the 6 locations in Europe. So just a few weeks ago, we were in Hamburg, in Germany, where we have a full week of training, which is tailored to the needs of fellows at a certain point of their PhD program. But we also have these immersion community events where local organizers gather potential employers for us in the future, or companies and institutions that might be interested in this kind of profile of health data or health intelligence professionals. So in the last Hamburg meeting, we've met with a large insurance company, we've met with a consulting company, and what was the third one? And a pharmaceutical company. In previous meetings, we've also met with institutes dealing with registry data. We've also met with national public health institutes, with ministry. So it's a very varied mix of stakeholders in these immersion events. And what is kind of what connects all of this is that there is a need, obviously, for health performance intelligence professionals, one way or another. Then we organize different webinars, data hackathons, and stakeholder engagement events. And there is this moment of applicability of our research. So a lot of fellows are, besides working on full-time, basically on their PhDs, are involved with different projects, either with the universities they're at, or the companies, or small consulting projects with European countries, applying directly the knowledge and the research they're doing within the HealthPros project. And the reason why Mircha and me are here is that this project is big on these transsectoral placements. We have to call them placements here. Basically, throughout these 3 or 4 years of our PhD streams, we have to spend at least 8 months doing a placement in another location. Most fellows will do at least, or all fellows will do at least 2 placements in different locations in different partnering organizations. Yeah, so talking about these placements, Mircha will tell about his work and his placement here.
Just a second to change the mic. So our work, and I'm the first to speak. I put the broader context of my PhD fellowship on just one slide. The overarching theme of my PhD is on the effective use of performance reporting in long-term care. The way that the PhD is structured, the way that we are doing it at the University of Amsterdam, goes through publications. So we are preparing about, expected to prepare about 5 to 6 papers, and then giving a general introduction and discussion to those that comprises sort of our PhD. So in that context, our work goes sort of paper by paper. I will speak in more detail, obviously, going on about the one that I'm working on here in Canada. I would like to mention the other 3 that I'm currently working on as well. The second one is a scoping review of performance frameworks and indicators in long-term care. The idea here was to initially look at all the indicators that are out there in the area of long-term care. This obviously is too big of an endeavor. There are thousands of indicators. But then we realized that what we're really looking for is how authorities, particularly countries, subnational entities, are monitoring their long-term care system. Hence, we deflected the attention and reframed it as frameworks and indicators, looking at frameworks and indicators that are used in countries or subnational entities. And I'm looking at this through a systematic review of the scientific literature, but also looking through websites where actually I expect to find most of the information. Another paper that I'm working on is an international comparison of pressure ulcers in long-term care facilities. This is connected to a work that the OECD has been doing, or I have been collaborating with the OECD in doing. So for those who don't know, OECD is the Organization for Economic Cooperation and Development. It's an international think tank of mostly rich countries, and it publishes once every 2 years a flagship publication in the area of health called Health at a Glance. About a month ago, when the last Health at a Glance was published, it also included a table on the prevalence of pressure ulcers in long-term care facilities in different countries. Those data were based on point prevalence surveys that were done by 2 institutions. You might be familiar with the CDC, the Center for Disease Control and Prevention in the United States. There is also a counterpart, a correspective organization in Europe. It's called the ECDC, the European Center for Disease Control and Prevention. And they did very similar point prevalence surveys. And the OECD, I also participated in that work, pulled together those data to create a common table. Now the question becomes methodological. Can we do that? What are the differences between the 2 surveys? And then there are also other surveys that sort of took the inspiration from the work that has been done by these 2 organizations and reproduced it in their own countries. So this paper will look at the methodological differences between these different surveys. The 4th paper that I will be working on, it's a risk model. That's a collaboration with the Health Inspectorate in the Netherlands. So again, as opposed to Ontario, at least in my understanding, here the inspections are done in long-term care facilities annually in all the long-term care facilities. Well, in the Netherlands, they do them by sample, so they don't manage to check all the long-term care facilities every year, and they have to choose which one to look at. For that, they use a risk model. They already have it. They want to change it in such a way that it takes more into account performance data of long-term care facilities. And here is where I will collaborate with the inspectorate. The work that I'm doing here, as Sarah already mentioned, is about the impact of public reporting of performance measures in long-term care. So focusing on this one, the broader concept, the idea is that public reporting is important in the context of external accountability. That much we know. As a fact, it increases transparency, and it increases at least the potential for patient-informed choices. Whether these data are then used for patient-informed choices is a different question. However, the hope is that the publication of indicators also has an impact on internal improvement. Systemic reviews that have been done so far were not very decisive in finding a connection. There is mixed evidence going both ways, showing that there is or that there isn't an impact in public reporting. So my hope is to add a little bit to that body of evidence. And it comes into the context of what has been going on in Canada. In particular, on the portal Your Health System, which is managed by CIHI, facility level data on quality indicators in long-term care have been published for the first time in June 2015. earlier, those data were published for hospitals, and then other settings were also progressively included. And the indicators in the area of long-term care included the 9 indicators that you see listed here. Even if you cannot read it because it's very far, it's not essential. What is important to know is that the same database on which these indicators were calculated was used to calculate a number of other indicators. There are actually 35 in total. The results of those other indicators, the 26 remaining, are sent as e-reports to the long-term care facilities and are not publicly available. And this sort of sets the framework for my work, which is looking at a choice of 8 publicly reported indicators. And here you might ask why 8 if 9 are publicly reported. There was one that we excluded, and that was on the use of restraints. That's because we felt that the use of restraints is so influenced by regulatory changes that have been going on in the past few years that it would be very difficult to sort that out, to divide that, so to take into account that additional variable in looking at the impact of public reporting. So 8 publicly reported indicators, and then we chose another 8 privately, for lack of a better word, reported indicators, one of those 26 remaining. And the criteria by which we chose it is, in a few words, just to make sure that those privately reported indicators are related to the least extent possible to the publicly reported ones, so that there is the least possible interaction between the two. And we can look at, I have a database that looks at the data from 2011 up until 2018. And as I mentioned, in 2015, the data were made public. A surprise when I came here was that it turns out that Canada does not have one healthcare system, but actually quite a few of them. Every province has its own setting, which sort of complicates the picture a little bit. I was aware that I would have needed to have some conversations with people to get a sense of the context. It appears that I need many conversations with many people to get a sense of the different contexts. So just to give you an example, something that perhaps may be trivial to you but was surprising to me, I looked at Ontario, for example, because it's mine to discover. So here's what I found out. HQO, for example, the Health Quality Ontario, published some facility level indicators, and that's actually incorrect already since 2010. And then they made some changes later on. Not only that, only in Ontario and Alberta, the same data set that is the basis for the calculation of quality indicators also goes into the calculation of the so-called resource utilization groups. And these then influence payment. Hence, what is the impact of that on reporting of quality? Only Ontario, to my knowledge so far, has so-called quality improvement plans that all long-term care facilities need to do, and for which there are HQO set priorities that they have to work on. Similar situations or peculiarities arise for more or less every province. There was one situation that I found particularly interesting and that I wanted to mention. So of these peculiarities, and this one is related to BC, to British Columbia. So your health system, as I mentioned earlier, published its data, long-term care facility level data, in June 2015. There is a body there called the Office of the Senior Advocate, which has quite some weight in reporting on the state of affairs regarding the seniors, also seniors' health care. So what they did was, in January 2016, so 6 months after the report of CIHI, they published what they called quick facts. So on 3 pages, reports on each long-term care facilities, which also included data on long-term care quality, the quality indicators that were published by CIHI on your health system. And that was sort of, at least partly, again, to my understanding so far, a response or at least indirect consequence of the publication by the date of the data by CIHI 6 months earlier. Now what happened was that the Vancouver Sun picked up on those reports and published a number of stories regarding long-term care quality. But not only that, it also asked the seniors advocate for the spreadsheet, and they published directly on their web pages, pages, the data that basically CIHI was originally reporting on your health system. Now, we can have a discussion about whether that was a good idea or not, because you have just the raw data, sort of very little, if any, contextual explanation and so forth and so on and so forth. But I think what is particularly interesting, or what I wanted to point out with this story, is the fact that we cannot reduce the measurement of the impact of reporting of public indicators to, for example, just looking at how many clicks there were on the web page of your health system by CIHI. It turns out to be actually quite a more complex story. So this is in terms of background, and I have been doing a number of consultations, and I will still do a number of consultations with people who are knowledgeable about what has been going on, from the ministry to healthcare workers in nursing homes, and also any feedback from you are very welcome, looking to understand better what has been going on. But going into the actual data set, I had a number of data from a number of facilities, 1,300 approximately, more than 1,300, but I took the cohort of only those facilities that had the data since 2011. And for this reason, not only do I have less than that, 984 facilities, but they're mostly from 4 provinces: British Columbia, Alberta, Manitoba, and Ontario, from which actually 2/3 of all the facilities come from. So this is the sort of data set that I have been working with, and now I'm going to just show 3 snippets of findings which seemed interesting to me. Perhaps they might be also to you. One of the things that I noticed was then, if I looked at the 8 publicly reported indicators and at the 8 privately reported indicators, a lot more seem to be happening, bigger changes, more consistent changes, whether for the better or for the worse, with the publicly reported indicators than with the privately reported ones. Now again, talking about 8 indicators, it's not exactly statistical relevant, but it sort of suggests that perhaps something is going on. However, and what you see here, I guess it's hard to read from a distance. So what you see here in all of the graphs that you will see is on the x-axis time, going from 2011 to 2018. On the y-axis, you have the adjusted value of the indicator, which is different for each graph, and in different colors are different jurisdictions, provinces in this case. So red is Alberta, purple is Ontario, green is British Columbia, and yes, and what's this, blue is Manitoba. So, on the indicator on the use of antipsychotics saw a reduction in the percentage of residents using antipsychotics. We're doing well. There's also a reduction in the percentage of residents with pain. So there is improvement there. Not so evident, that improvement, when we look at other 2 indicators, such as the percentage of residents who had unexpected weight loss and the percentage of residents with a feeding tube. And those 2 indicators are privately, not publicly reported. However, the question becomes, is the trend actually impacted by publication? And what you see with the black line is the moment when publication started by CIHI. And again, bear in mind that for Ontario, some of these data were published already earlier. But first of all, you don't see a significant change happening with the publication itself. One might speculate that changes started already earlier because nursing homes were preparing for publication. But another quite convincing explanation would be that the same reason for which you see changes in those publicly reported indicators are the reason that brought to the decision to publish those indicators, because they grab more public attention, more policy attention. They seem to be more important and more relevant at all levels, by experts, the general public, and or policymakers. There is a case where the opposite can be seen, the case of falls. So if we look at falls, the rate of falls has been increasing, more patients have been falling over time, and that was before and after the publication of the data. And again, here the speculation for the reasons for that, and I don't have an explanation yet for Manitoba up there, which you see. So I'm still trying to figure out what happened in Manitoba. But as for the other jurisdictions, the explanation would be that as we reduce the use of antipsychotic and the use of restraints, people tend to move more, and hence there is a higher risk for falls. Some have argued, again from the consultations that I had, that it would be more appropriate to actually look at injuries following falls as a more pertinent indicator, but the jury is out there. There are actually there isn't consensus as to which one would be the better indicator among experts. The last bit that I wanted to show you in terms of interesting finding is on the relation between the those indicators where you have an improved and worsened side of more or less the same indicator. So here we are looking at mid-loss activity of daily living functioning. To trivialize the indicator, it's about the ability to transfer and move in function of activities of daily living. So what the graph on your left shows is the percentage of patients where we saw improvement. And what the graph on the right shows is the percentage of patients where we see worsening. Now, one is not one minus the other, that's a given, but they are very similar. They do use the same inclusion and exclusion criteria. And in the next slide, I have worked out the exact differences. But what is surprising, whatever way you interpret it, is that as you have an increasing number of patients who improved on that indicator, you have also an increasing number of patients who worsen on the indicator. Or in the case of patients who have worsened on the indicator, they also seem to have worsened, who have, as less patients have improved on the indicators, also less patients have worsened on the indicator. Now, here again, the objection might be, and I should warn you that the scale does not start at 0, that this is not a statistically significant change, which I have to check, but it's probably the case for a number of these graphs. However, it's a pattern that I see also with a number of other indicators where we have an improved and worsened parallel with communication, with locomotion, and with bowel continence, which are some of the indicators that I have been looking at. So it's quite an interesting finding that I haven't been able to explain yet. What I found was that the differences between the two indicators are in the risk adjustment on the one side, and which might explain the difference, and on the other side, the inclusion of residents who, as for the improved part, remained completely independent, and for the worsened part, remained completely dependent. So to recapitulate, sort of speak, it might be that there are more patients who are completely independent and at the same time more patients who are completely dependent, and that would not be a contradiction. Now, why is that the case? Is that it's actually the reality or just a change in coding practices is a question that is still open. However, these are just some food for thought that I wanted to put out there. And as you can see, there is much more analysis that I need to do. And so I'll stop here and give it over to Damir.
Thanks, Mircha. I'll try to now briefly talk about my PhD work and specifically what got me here, previous work in Europe that's linked to the one here in Ontario, and then try to leave enough time for your questions and trying to help Mircha make sense of the indicators. So basically, my topic of my PhD work is results-based corporate governance tools in healthcare. So more specifically, it's on the use of tools that are often used in the corporate sector and that are basically governance tools based on the performance data and results data. And to do that, to work on that topic, in my first year of PhD, I'm kind of doing an environmental scan or getting an overview of the landscape of working with performance data in different aspects of healthcare and different healthcare systems. And for this, I've been focusing on these three kind of sub-studies or papers that I'm working on. The lowest one, the lower one, the public reporting, that's the one that I started first. So basically, I'm looking at public reporting of comparative performance data in healthcare for both healthcare systems, so international comparisons between countries, and also within countries. So within one national healthcare system, how does comparative reporting of services look like? And I'm looking at that through a lens of communications theory, the science of communicology. Basically, because as Mircha mentioned, it's still not clear how and whether public reporting works to improve quality and performance in healthcare. And my hunch is that it might have to do with how the performance reporting, especially the comparative one, gets done. And so I'm looking at websites doing this international and national reporting of performance data, and anchoring the analysis in a communication theory, seeing whether it's really clear what's the purpose of reporting, who is the target audience, and whether the layout and the visualization, but also the content, so the form and the content of reporting is fit for the intended audience. Preliminary results of that work show that that might be one of the explanations, that it's often not really clear who the reporting is for. Hence, it's not clear really what the needs of the target population are. Hence, the use and the effect of public reporting might be dampened by that a bit. But what I really want to talk about here are these two other studies that I'm working on with a very similar name, a different geography. So why, what, and how healthcare managers use performance data for decision making. And the part of the research that I've done earlier this year was in Europe, and now we're replicating that in partnership with OHA, so the Ontario Hospital Association in Ontario. In Europe, so I'm here partnering with OHA, and in Europe I've partnered with HOPE. It's the European Hospital and Healthcare Federation based in Belgium, and it's basically a European association of national hospital associations with 30 European countries involved. What HOPE does every year is a so-called HOPE exchange program, where around 150 hospital managers, usually mid-level hospital managers, go to another European country for 1 month in order to get an overview of how managerial work, but also healthcare system in general, works in another country. And all of these hospital managers then gather at the so-called Agora meeting immediately after their 1 month study visit, where they exchange experiences. So this was our study population this spring when they did the exchange program in April. And we got quite a good response rate from this year's participants, and some responses also from previous year's participants. As you can see, a lot of European countries were covered with this survey, and most of these exchange program participants and respondents worked in hospital. Most of them worked in publicly owned hospital, which is mostly the case in Europe also. In terms of their managerial positions, there was an even split between people managing plans and strategies for the whole organization, and between managerial positions dealing with clinical processes and also the support of clinical processes. And how we've then structured the results of the survey, and what we aim to do here in Ontario also, is to see why do managers use performance data for their decision making. So what's the motivation? Then what do they use as performance data? So in terms of what types of data, but also which types of reporting. and how, basically what are the methods and tools in turning performance data into decisions in their daily work. No? So in terms of why, what we found out is that considerably they use performance data to make decisions, but also they said that even more they use performance data to justify their decisions that might not be exactly evidence-based or based on the performance data itself. Additionally, what I forgot to say, during this Hope Agora, when all of these managers got together in one place for 2.5 days, we went there, so also Mircha and me and our supervisor. We went there, and then we already had the preliminary results of the survey, and we organized kind of a session with all these 150-ish managers, asking them, showing them the preliminary results and kind of contextualizing them and validating them and asking them about some things that might not be as clear from the results as we thought they would be. So performance data is used considerably for decision making on this level of management, but it's also used to justify their decisions. Motivation to use performance data is both, again, internal and external. Internal in terms of internal quality improvement and internal quality assurance, and external in terms of benchmarking with other comparable organizations and reaching a specific level of standard that's needed for external reporting. Benchmarking as a motivation kind of lags behind these other motivations, so it's still not used as much. And privately owned organizations seem to be more motivated to use performance data for decision making than the publicly owned ones. There was considerable or very high confidence in validity and reliability of data, but we've also noticed that there is a kind of a west to east gradient within Europe in terms of what the confidence is in using data, where it is higher in Western European countries, which might do with a lot of things. One of the interpretations was also the data collection methods, which are still not completely digitalized in some Central Eastern European countries, while in Western Europe, that's mostly the case. More on why managers in hospitals use data for performance data for decision making. It seems that the motivation to use performance data does not differ between managerial roles or levels of experience, but it does differ based on the organization's ownership. So it seems that private for-profit organizations, mostly hospitals, are more motivated to use the data and to decide based on it. And what, again, the kind of the contextualization of that was that they have more financial incentives to do that, while in publicly owned hospitals, often managers don't really have incentivizing or disincentivizing tools. And also because they're held more accountable for their financial results than the ones in publicly owned hospitals. Then we looked at what kind of data is used for decision making, what categories, what domains of performance data are used. And it seems that a lot of data, pretty much everyone agrees that a lot, maybe even too much data is collected, but that then less of it gets analyzed and reported, and even less of it gets really used for decision making. So we saw this cascading in all the categories of data. So we looked at effectiveness performance data, efficiency, safety, and patients is basically patient-reported data, which is, again, lagging behind these other categories, but it is a big, like here, I suppose it's a big talking point in Europe in working more with patient-reported data and defining outcomes more based on patient-reported outcome and experience measures. And what some of the comments on these results were that we have a lot of data, we have enough data, but we need to know how to use it better. We need to improve our data collection processes and automatize them more. We need to collect more patient-reported data. We need to, in terms of working with performance data, the silos of data seem to be also an issue. So there is this push to work on a kind of singular patient health record, which would include different types of data in it. and also that sometimes the way performance data and indicators are defined, the so-called hard data, that it needs a lot of contextualizing in order to turn it into the so-called soft intelligence and basically decisions in daily managerial work. How do they use them? So we asked about the ways of reporting on performance and what are the most prevalent ones, and written reports are still kind of the static written reports are still the most prevalent way of reporting on performance, but more corporate ways also, but more interactive ways of visualizing and reporting on performance are also prevalent, so like dashboards, control charts, scorecards. Respondents in this survey were less likely to really work on collecting and reporting the data. They reported more on using the data that they get from other parts of the organization and other sources. And an interesting finding I thought is that the operational level of management uses more performance data in their decision making than does the strategic level. And what was recognized as a need in improving the work on performance data for decision making were financial resources and time for people working with data, but also improved competencies in data analysis and visualization. This is a rundown of basically the reporting methods used, where I've heard while testing this survey here, which it still seems to be relatively prevalent in Europe to use verbal reporting as a valid reporting method for performance data. What I've heard here is that's a big no here. So if it's not written somewhere, it doesn't really count. But you can see that the other methods of reporting are also relatively prevalent. Most organizations use multiple, of course. And again, an interesting finding that performance data is used more on the operational level, so the care process management and the support functions for the care process, than it is on the strategic level. And we found this to be statistically significant, this result. And yeah, so I have some quotes from the survey and from the panel that we organized with participants, and assistant to CEO in a German hospital said that they see that evidence-based decision making is more prominent in these process-related activities in hospitals than it is on a strategic level, because it seems easier to apply these performance metrics to basically process topics. And I think I'll end with two more quotes from this session by participants, which kind of point out what their benefit of using performance data for decision making in their daily work was. And one was a quality manager in a Slovenian university hospital, saying that working with this performance data, especially being able to report it and visualize it, changes the whole dynamic and narrative of talking between different managerial levels in hospitals, and basically what they can talk better and differently to clinicians, and also they can show that not every change is an improvement. And a clinical ward manager in a Dutch hospital said that thanks to using performance data, they now see that also that clinical work or that healthcare is more forecastable than they thought, having all this data. Yeah, so that was this spring in Europe. What I'm doing here briefly is, again, in collaboration with CIHI and the NAO and IHPME and Ontario Hospital Association, we are replicating this survey among all the hospitals, or almost all the hospitals in Ontario, members of the Ontario Hospital Association. We did minor changes to the survey, piloted it here in Toronto and surrounding, and we feel that we have the comparability aspect of the survey preserved, so it'll be interesting to compare the results. Survey was sent out last week, and yeah, we already have a fantastic response to it, so it'll be really, I'm super excited to work on analyzing the results and talking about them. What we plan for the future, hopefully, similar to what we did in Europe, that we'll have an opportunity also in different training events that OHA organizes to present the results and discuss them with basically the participants of the survey, and to see whether we can make sense of the results and see what could be done. Next year, with the HOPE, with the organization that we've partnered in Europe, during their next year's exchange program and the Agora meeting, we will build upon these results, looking at how hospital-based performance metrics can be and are now extended to kind of more community health outcome metrics. So how much are the hospital information systems integrated to what happens to the patient before he ends up in a hospital, or she, and what happens afterwards. So yeah, we're building upon these results, and hopefully we'll be able to do that here in Ontario also. Mircha will end with some of our colleagues joining you here soon.
Yes. It's actually just one slide. The next generation. The next generation is comprised of 2 fellows, so we will be leaving at the end of this month. Other 2 students from our 13 PhD students that were presented earlier by Damir will be joining the NAO and CIHI. Erika in January 2020, right after us, next month, and her work is on the transferability of actionable indicators, so on how to make indicators work. And Kendall will be coming in April, and his work is centered on the role of managerial system in promoting integrated healthcare pathways. As far as we are concerned, we probably want to be reachable on our U of T email. However, we are happy to stay in touch, and hence we provided our Amsterdam emails, and we'll make sure to disseminate the results of the final results of our work once they are available. So that was all from our side. Thank you.